patient or medically manage a patient. Polysomnography or sleep study will only provide us with the AHI, which only assesses the severity of the condition but doesn't give the anatomical trait and the non-anatomical traits which constitutes the condition. So one size doesn't fit all when we are managing cases of OSA. So a patient can present with different modalities of presentation to different departments. He can present with the ENT department with a nasal block or snoring. He can present with a cardiologist with uncontrolled hypertension patient, especially when a patient is on 2 or 3 antihypertensives and still not getting control. It is high time that we have to suspect OSA, and cross consultation needs to be given so that we can manage the patient adequately. Similarly, patient can present with shortness of breath to a pulmonologist, or posture problems with a spine surgeon, or an orthodontist for malocclusions, or a urologist for nocturnal enuresis, or a neurologist for uncontrolled migraine, and with a psychiatrist with behavioral issues because of sleep fragmentation and multiple other issues. So when we talk about snoring, it encompasses 4 conditions. 1, primary snoring, upper airway resistance syndrome, obstructive sleep apnea, and obesity hypoventilation syndrome. It is imperative that we differentiate all these 4 conditions before we jump on to investigate them. So when it comes to primary snoring, the patient only suffers with snoring but doesn't have repeated arousals or desaturations or type 2 respiratory failures. When it comes to upper airway resistance syndrome, along with snoring, patient has repeated arousals but doesn't have desaturation or type 2 respiratory failures. In a patient with OSAS, patient has snoring, he has desaturation, he has repeated arousals but doesn't have type 2 respiratory failure. In a patient with obesity hypoventilation syndrome, patient have all the above 4, including type 2 respiratory failure. That means even when the patient is awake, patient is having desaturations. So our evaluation should encompass that we address both anatomical traits and non-anatomical traits. So as mentioned earlier, we need to find the right tool to open the right door to manage the patients adequately. So I'm going to give a quick overview. When it comes to history taking, we have been quite well versed with that now. Snoring being the most predominant complaint. Along with snoring, we have apneas, sleep disturbance, sleep fragmentations, unrefreshed sleeps, excessive daytime sleepiness, fatigue, unproductive at work, falling asleep during driving or at work, or depression, or dry mouth. So what are the more relevant questions which we tend to miss out while taking a history in a patient working up for OSA? One being whether a patient is having insomnia, that too specifically maintenance insomnia. Initiation insomnia is more towards sleep disorders. Maintenance insomnia is mainly because the desaturation patient can have repeated arousals and patient might be having maintenance insomnia. History also we need to emphasize on whether patient is having any nocturnal movement disorders, a patient is on a regular alcohol, whether patient is consuming regular alcohol intake which can affect the REM sleep and increase the apneic episodes during the REM sleep, whether the patient is having on any other medications which can be seen as a depressant, whether the patient is taking any beta blockers which can be a hindrance to our DICE studies, because for example if the patient is on beta blockers and if you're going to use dexmedetomidine, patient can have bradycardia during the procedure. And relevant medical history needs to be taken, whether during the childhood, whether the patient had any childhood related breathing disorders, sleep breathing disorders, whether the patient had any history of adenoidectomy or tonsillectomy, any of these procedures has been done. All these needs to be documented. And family history of narcolepsy and psychosocial history plays a big part. When it comes to assessing the daytime sleepiness, the most common questionnaire which we use is Epworth sleepiness scale. This doesn't give the severity of obstructive sleep apnea, it only tells us what's the propensity of the patient to fall asleep. So it's the advantage of these kind of questionnaires is you're involving the patient to be a part of the survey, and the patient is much more involved when you involve him. So it has 8 questions, and based on the total score, we have like 0 to 5 for lower normal daytime sleepiness, 6 to 10 for higher, 13 to 15 for moderate, 16 to 20 for severe. The other sleep scoring system will be Karolinska sleepiness scale. Coming to the next most important questionnaire is Stop Bank questionnaire, which is an acronym. The importance of this being, this tells us it can predict the severity of detecting obstructive sleep apnea. The sensitivity and specificity is quite high for Stop Bank questionnaire. It has an 87% sensitivity for detecting moderate to severe obstructive sleep apnea. So the acronym STOP. S stands for whether the partners witness any snoring episodes. T for tired, observed, any observed apneic episodes, and patients having any high blood pressures. When it comes to B, it's for BMI more than 35 kg per meter square, age more than 50 years, neck circumference more than 16 inches, and gender being male. For Indian population, we need to lower down the BMI to 30 and the neck circumference to 15. This increases the likelihood of including more patients, especially in Southeast Asian populations. So when you come down to the final score, if the patient is having a score of 5 to 8, he has a very high risk of obstructive sleep apnea. So when it comes to a clinical evaluation, we need to assess the airway right from our nose to larynx. Because we have a rigid skeletal framework and soft tissue, it's imperative that we assess all of these in a functional manner. So we need to assess the patient in an awake state, in a dynamic assessment, and also during sleep. So when it comes to clinical examination, we need to see for any craniofacial morphology. We have to get a cephalometry to assess that, and morning we saw how a cephalometry helped us in determining the measurements. And when it comes to nose and piriform aperture, how high arch palate can affect nose, and the transverse diameter of piriform aperture needs to be assessed. When it comes to nose, we need to see the external nasal valve, the internal nasal valve. Is there any collapse at these two levels? Is there any history of allergic rhinitis? Is there any symptoms of allergic rhinitis? Any signs of allergic rhinitis? And we can assess these by objective measures. We can use rhinomanometry and acoustic rhinomanometry, which can tell us the airflow and also the resistance. Acoustic rhinomanometry helps in assessing the surface area. And we also have to, we're going to talk about palatal phenotypes in the further slides. So also in cephalometry, we need to see where the hyoid position is when compared to the C3 Megonian line. If it is below that, the severity of obstructive, the chance of patient having a OSA, severe OSA is much higher. And we also need to see the position of the mandible, position of the maxilla and relative to each other. Whether patient having retrognathia, this can decrease the retrolingual space. And the long pharyngeal segment. Whenever patient is having a long pharyngeal segment, the chances of increasing a collapsible part of the segment is much more. So when a patient has a nasal septal deviation or a nasal polyp or a turbinate hyperrhinitis, it increases the nasal resistance. When there is an increase, there is increased more chances of mouth opening and mouth breathing, and the collapsibility of the lower pharyngeal airway is much more. And other importance of nasal resistance is if the initial few days when the patient has been prescribed for a CPAP, and because of the patient is having any of these nasal conditions, the CPAP pressure needs to be much higher, and if in the initial few days patient finds it uncomfortable, the likelihood of the patient using CPAP further will be much less. So before we initiate CPAP therapy, it is imperative again to send it to an ENT consultant who can pull out any nasal causes before starting CPAP. Another thing which we tend to miss out is assessing the transfer diameter of the piriform aperture. There is a very famous saying, form follows function. So if the kid is breathing through the mouth, he is going to end up having a high arch palate. This is going to decrease the transverse diameter of the nasal aperture, piriform aperture, sorry. So when this happens, even if you do say for example, patient has a DNS and you do a great septoplasty or turbinoplasty, the results are not going to be optimal. So in these kind of cases, first on a CT scan, we need to assess the transverse diameter, especially at the level of 1, A being at the level of nasal bone and the frontal process of maxilla, and B being the maximum diameter of the piriform aperture. And we also need to assess the shape of the piriform aperture. So this is a graph for a rhinomanometry results. So this helps again to assess the nasal airflow, where the resistance, and also in acoustic rhinometry we'll be able to assess the cross-sectional area. When it comes to the next oral cavity oropharynx, we need to assess the mouth opening, whether it's 4 centimeter. We need to assess the interincisor distance. We need to see for any glossomegaly or scalloping of the tongue. We need to see if there is any retrograde parachuting of the soft palate when you ask when you elicit a gag reflex, or when you ask the patient to say, is there any retroshooting of the uvula? We need to observe for. You need to see if there is any corrugated uvula or any TMJ arthropathy, or retinal hypertrophied lateral pharyngeal mucosa or scarring at the velopharynx. So when it comes to assessing the tongue and with this relation to the oropharyngeal structures, one popular classification system is Friedman tongue position and Malampati classification. So why do we need to use these classifications? One, they can assess the severity of the condition.
Vignesh, keep a watch on your clock, okay?
Okay, sir. So yeah, so I'll try to. The other being, for oropharynx, we need to see whether any lingual tonsillar hypertrophy or retrolingual space, and for epiglottis position, because if there is any retrolingual displacement, this can affect CPAP. Other thing we need to assess is palatal phenotypes. There are 3 types of palatal phenotypes: vertical, oblique, and intermediate. A being the oblique one is the most favorable one. So basically, we have to see the proximal and distal segments of the soft palate and the angle between them. The alpha angle we need to genu we need to assess, and also the alpha angle is the one between the hard palate and the soft palate. If it is acute, and you can see the retrolingual retrovelar space is much more for the patient, and the collapsing segment is circular. If it is more acute, like in C, the patient is going to end up having a vertical soft palate, which is going to have a decreased retrovelar space. For the base of tongue, we have Moose classification, wherein we're going to assess whether the collapse is at the superior part or the inferior, only at the epiglottis, or both. So how we going to assess this? By the means of a flexible scope. Transnasal flexible scope, we will be able to assess all the retrolingual assessment, and also Cormack-Laney class. This informs us the ease or the difficulty with which the intubation can be done. And also, when you're doing a flexible scopy, again we need to assess 2 things: at the end expiratory flow and at the inspiratory, how was the cross-sectional areas. So all these give us anatomic clues of how the obstruction is, or the level of obstruction, the degree of obstruction. Sleep study gives us the severity of the obstruction. So we have different 4 levels of sleep study, and usually level 1 and level 2 are observed sleep study with 7 parameters. Level 1 is observed, level 2 can be done at his home or at his convenience. Type 3 and type 4 usually not favored. Type 3 can be done if they don't have any other comorbidities. So there are certain important parameters which we need to look in sleep studies. Sleep studies will be covered in further talk, so I'm going to skip this. So as we saw in the morning, that is 50 to 70% of this plan can change based on TICE finding. That's one of the most important things of dynamic assessment during sleep. It's more like a snapshot of the entire sleep cycle. We are, by pharmacologically, we are inducing them to sleep, and we're just taking a snapshot. We are won't be able to assess how is the collapse at different stages of the sleep, because during different stages of sleep, the collapse pattern can be different. So what are the advantages? One, real-time observation at the pharyngeal laryngeal levels. Retropalatal closure patterns can be observed, and it can also be combined with the interventional studies, and also we can titrate CPAP to set the optimum pressures. So we're going to score these based on word classification. Word, Vellum, oropharynx, and tongue base and epiglottis. Whether we're going to see whether there's any obstruction, no obstruction, or complete obstruction. Or when there's no obstruction, you also have to look for any vibrations. So what are the disadvantages? One, it is not natural.
15 seconds, please.
Yeah. So at the end, after the functional evaluation, we need to have 3 things we should have evaluated. One, whether it's a global or a local. What I mean is whether the patient is having OSA because of obesity, or whether it's more of a local obstructive factors, whether it's a soft tissue or a skeletal patient, or whether it's a static obstruction or a dynamic obstruction. Thank you.